Thank you for your very kind words. So, good afternoon, everyone. I know it's a difficult time just after lunch. I mean, in Greece, we would usually have a siesta now, for half an hour, but I hope I can stimulate your attention with my presentation. So I would like to start with a case just to emphasize, exemplify the difficulties we face when we treat patients with aggressive lymphoma. So this is a 56-year-old male. He presented to ER with constitutional symptoms, hepatomegaly, jaundice, and the initial working diagnosis was biliary pancreatitis in the ER, but it turned out to be something more complicated. So he eventually had a PET scan which showed multiple lymph nodes above and below the diaphragm. The liver, as you can see, was heavily infiltrated by a disease, and he had probably also hepatic nodules. So he had a liver biopsy which confirmed that he had diffuse large B-cell lymphoma, NOS, non-GCB subtype. Despite non-GCB, we did do FISH rearrangements, but they were negative. He had high LDH, and the overall stage was stage 4B. So the patient was treated with 6 cycles of R-CHOP, and he had an endothelin PET scan, which, if you're thinking about it, he had a very good response, but he had 2 residual lesions, as you can see, in the split in the liver. So he was DLBCL 5 primary induction failure. So what do you do with patients who have relapsed or refractory disease? The standard of care at that time was salvage and auto. And the CORAL study demonstrated that, first of all, it compared RDHAP with RIs, but this is not the point of me sharing it. It's just that 50% of patients 60% of patients respond to salvage therapy, 50 will proceed to auto, and the 3-year event-free survival is 45% in those who have relapsed beyond 12 months, but 20% only in patients who have primary induction failure or relapse within 12 months, as you can see in the figure. So this patient received RDHAP 2 cycles, a PET scan after the salvage was DLBCL 5, even though the previous lesions had gone away. He had a new lesion now, as you can see on the PET scan, so clearly progression DLBCL 5. So what is the outcome of patients who fail salvage therapy? From the CORAL study, you can see here that the overall response to second-line therapy is 39%. Of these patients, only 31% will proceed to auto, and the median overall survival of this entire group is only 4 months. So it's clearly a group with poor prognosis and poor outcome. What about patients who failed 2 lines of therapy and are not eligible for auto stem cell transplantation? These patients too, as you can see, have a poor outcome. Event-free survival after second-line therapy, 5 months. Third-line therapy, 3.6, and median progression-free survival for the entire group, 4.1 months, and overall survival, less than 12 months. Again, dismal outcome. So these patients, in addition to patients who fail auto, were the subject of 3 phase 2 studies that looked into the efficacy of CAR T-cell therapy in patients with relapsed refractory diffuse large B-cell lymphoma who failed at least 2 lines of therapy. And these were 3 studies that looked at CAR T-cell products which were Axi-cell, Tisa-cell, and Lisa-cell. And I'm clearly showing you the results of the ZUMA-1 study because it has the longest follow-up. And as you can see here, with 5 years follow-up, the progression-free survival is just above 30%, and with a clear tail in the progression-free survival curve, which clearly indicates that these patients are cured. So we can say safely now we have adequate long-term survival data to suggest that it is a curative treatment in these patients. And you can see the overall survival of the ZUMA-1 at 5 years was around 42%. Now this was confirmed also in a US CAR T-cell consortium study, which clearly is the real-world data patients. And this was presented at ASH just recently. And as you can see, the 5-year progression-free survival was slightly lower, just below the 30% mark. And the overall survival was 40%. We should take into account that in this real-world setting, 42% of patients did not meet the ZUMA-1 eligibility criteria, so they wouldn't have gone on to ZUMA to receive it. I think we should emphasize that patients die of toxicity, so the non-relapse mortality in this study was 16%, and there is a proportion of patients who develop secondary malignancies, as you can see here. In this US real-world data study, 5% had myeloid. So in 2021, which was the treatment algorithm for patients with relapse refractory, so as you can see, patients who were eligible for auto went on to platinum-based therapy and onto auto if they responded, and if they failed, they would be eligible for CAR T-cell therapy. For patients who were not candidates for auto stem cell transplantation, they would receive second-line therapy, and again, those who failed would be eligible for third-line therapy, which also included CAR T-cell therapy and a variety of agents, as you can see there. So going back to our patient, so he had DeVille 5, so we referred him after failure of 2 lines of therapy at that time point to a center that provides CAR T-cell therapy. Their cells were collected and they were sent for manufacturing. The patient came back to us. We bridged them with radiotherapy to this residual lesion he had in the liver. But because there was a significant delay in the cells being sent back, we also gave him a cycle of RIGIV. He achieved a metabolic CR, DeVille 1, and we got the phone call from the CAR T-cell center, sent the patient, so the patient was sent and he received the CAR T-cell therapy. So as you can understand, since the CAR T-cells worked good in patients who had failed 2 lines of therapy, it was reasonable to think, why not push it to second-line therapy? And this was the purpose of 3 large studies, 2 of which were positive, which compared patients receiving standard of care salvage plus auto versus CAR T-cell therapy. So this is patients who have primary induction failure or have relapsed within a year. And this is the update of the ZUMA-7 study, clearly because it has the longest follow-up. And as you can see here, in the progression-free survival in the CAR T-cell arm was 42% compared to 24% in the standard of care arm, which is highly statistically significant. If we look at the overall survival, just recently it was demonstrated that there's a statistically significant improvement in the overall survival in the CAR T-cell arm. As you can see, 55% versus 46% in the standard of care salvage plus auto. One could argue, why is it so good in the standard of care arm? The answer is the study did not allow crossover, so 57% of patients received third-line CAR T-cell therapy off protocol, clearly indicating this, around 50% of patients were alive, which is pretty good, clearly indicating that even as third-line therapy of CAR T-cell therapy works even in these patients. Again, non-relapse mortality in this earlier setting is still there, 10% of patients, around 10%, and there is a risk of secondary malignancies. Now, these are the CAR T-cell indications from 2016 to 2021 as from the IBMTR. And you can see clearly that the majority of patients receive CAR T-cell therapy of patients with large B-cell lymphoma. And on the right, you can see this figure of patients who received CAR T-cell therapy for large B-cell lymphoma. And in blue, you can see the patients who went on to CAR T-cell therapy without an auto before. So this was 33% in 2017. But in 2021, 81% of patients went on to CAR T-cell therapy without prior auto. So this clearly shows the switch in the indication of CAR T-cell therapy. So this is the new algorithm based on the results of these studies, and you can see that patients who fail chemotherapy in the upfront setting within a year, they're eligible for CAR T-cell therapy, but still those who fail beyond 1 year are eligible still for auto stem cell transplantation. And those who fail both categories, they are eligible for second or third line options, as you can see in the figure. Going back to our patient, he received CAR T-cell therapy. But soon after, within 2 months, he progressed. He had developed a soft tissue mass in the upper jaw in the canine tooth. And we did a biopsy of that. It was high-grade B-cell lymphoma, and he received radiotherapy. So the question is, what immunotherapy options do we have for these patients, apart from CAR T-cell therapy? The answer is, we have the antibody-drug conjugates, polatuzumab vedotin, we have loncastuximab tesarin. We also have tafasitamab in combination with lenalidomide, and the bispecific antibodies that target CD20, glofitamab and epcoritamab, which I'll touch upon these immunotherapies. So this is the pivotal study of polatuzumab vedotin, which is a anti-CD79B antibody, which is conjugated with MMAE, which is a microtubulin disrupting agent that is also used with brentuximab vedotin. And there was a phase 1 run-in study, which was followed by a small randomized phase 2 study, 40 patients in each arm, comparing pola-BR with BR. And there was also an extension cohort, including 106 patients, which included also 35% of patients who were treated as second-line therapy. Now, based on these results, as you can see here, first of all, in the main study, the overall response rate was 62% versus 25% in the BR, and CRs, as you can see, 52% versus 22% in the main study. Progression-free survival, 9.2 months versus 3.7, as you can see here, if you can see it. And if you look at the median overall survival, 12.4 months versus 4.7 months. If we look at the pooled cohort, you can see clearly that the best overall response was better in patients who received the combination as second-line therapy compared to those who received it as the third or beyond. And I think this is the most important observation here from this study, is that patients who are non-primary refractory actually have a very good overall survival who are receiving this combination compared to those who are primary refractory. So based on these results, this combination was licensed for patients who have failed at least 2 lines of therapy and are not eligible for auto stem cell transplantation. What about how does polatuzumab vedotin perform in patients after CAR T-cell therapy? You can see here clearly that so there is some activity. The overall response rate is 44%, with 14% of patients achieving CR. And you look at the progression-free survival, it's 10 months, and the overall survival is 17 months. So there is some activity even for patients who have failed after CAR T-cell therapy. What about tafasitamab? Tafasitamab is an anti-CD19 antibody. It works by inducing antibody-dependent cellular toxicity, as you can, sorry. How can I go back? One slide, sorry. Back. Okay, sorry. So, sorry about that, it's okay. So it also induces antibody-dependent cellular phagocytosis, as you can see here, and direct cytotoxicity after interaction with the malignant B cell. Now, lenalidomide has a direct cytotoxic activity, but it also induces proliferation and activation of the NK cells. So when combining these two, you would assume that you'd get a better increased anti-tumor activity, and this was actually the case. Now, if we look at the study that was conducted combining lenalidomide and tafasitamab, it's the L-MIND study. And this included patients who had relapsed refractory disease, which were not eligible for salvage therapy, for autologous stem cell transplantation, 1 to 3 prior lines of therapy, but it excluded patients who had not received, who were refractory to R-CHOP, it did not include patients who had more than 3 lines of therapy, and none of these patients had prior CAR T-cell therapy. And here you can see the treatment diagram. I think what's emphasized here is the dose of the lenalidomide. It was 25 milligrams for 3 weeks, and each cycle was repeated every 4 weeks. And the primary endpoint of the study was overall response rate. Here you can see the combined efficacy of tafas plus lenalidomide. If you look at the The TAFA working as a single agent, it induces a complete response of only 6%, as you can see here, lenalidomide 13.2, but when you combine these two, clearly complete response, as you can see here, 42.5%. This is the duration of response not reached in the study when it was initially published at 64% at 18 months. And there was a 5-year follow-up of this study just published and you can see that the median progression-free survival was 11.6 months and the median duration of response for the CRs not reached. So those who achieve responses have durable responses, but I must emphasize here, these are not heavily pre-treated patients. I mean, most of these patients had failed 1 or 2 lines of therapy. Actually, most of them was after 1 line of therapy. So we have to be cautious about treating patients with very aggressive disease after failing multiple lines of therapy with this combination. Well, casdiximab-tezorin is a antibody drug conjugate, which the payload here is a pyrrolobenzodiazepine, which practically, when internalized into the cell, it interacts with the DNA. It's cross-linked with the DNA, and it inhibits the DNA repair mechanisms and leads to cell death. So here, in this study, the LOTUS-2, which included patients who had failed at least 2 lines of therapy, it included also a small proportion of patients who had failed auto or CAR T-cell therapy, as you can see. The overall response rate was 48% with 24% CR, and the median duration of response was 10 months. Here you can see on the top here on the left, the responses depending on histology. And on the right top, you can see the adverse events grade 3 and above of particular interest. I'll just Some of the interesting adverse events is increased gamma GT in 16% of patients, and edema effusion in a proportion of patients, pretty low, 5% of patients. In an update of the study, you can see here that patients who achieved the CR, a significant proportion of these patients still maintained their disease-free status at 2 years, as you can see. Now, what about CD19-directed therapies after failing anti-CD19 CAR T-cell therapy? So, this is a question, how do these agents work? The answer is there is some activity, as you can see here. I mean, most of these patients had received TAFA, 75%, and LONCA was 25%. You can see here the progression-free survival is 8 months, median overall survival 21 months, and you can see the activity, the responses and CR rates of each of these agents. Our question is, do we need to check for CD19 expression in patients who have failed, for example, CAR T-cell therapy, and we would want to give them one of these agents? Because as we know, around 30% of patients who fail diffuse large B-cell lymphoma, the failure is associated with loss of CD19 expression of the antigen. So this study clearly just tells us that you have responses in patients who don't even have a detection of CD19 based on immunohistochemistry. And if you can see on this Wilcoxon graph, so this is the H score. It shows us it's a semi-quantitative assessment of the percentage of CD19 positive cells, and clearly responses were seen in patients with all levels of CD19 expression. Clearly, as I'll emphasize on it with immunohistochemistry. So they saw responses even in patients who had failed CAR T-cell therapy and did not express significant levels of CD19 on their cells. So the bispecifics. Bispecifics are, as you can see here, 2 have been licensed, epcoritamab and glofitamab. Epcoritamab is given subcut and is indefinite therapy until failure of treatment, while glofitamab is given is in a 2-1 format and has 2 anti-CD20 molecules, as you can see. It's an IV infusion, and it's time limited. It's 12 cycles of treatment. Here you can see the 2 pivotal studies that led to the approval of these 2 agents in relapsed refractory diffuse large B-cell lymphoma. Both of these studies have a follow-up around 18 to 20 months. the median number of prior therapies was 3. 20% of these patients had failed prior auto. A third of the patients had failed CAR T-cell therapy, and more than 80% of the patients were refractory to the last treatment. So clearly we have a heavily pretreated population of patients in these two studies. And if you look at the overall response rates and CR rates, I just can mention here that the CR rates were similar. More than a third of patients either had received CAR T-cell prior or not. So there was no difference in that. In the relapsed or refractory, primary refractory setting, you can see that there was a difference. So patients who have relapsed have higher response rates, 70% and 53%, compared to those who had primary refractory, 34% and 30%. The median duration of response, you can see how much it was 18% in 18 months in glofitamab, 12 in epcoritamab. And the median duration of CR was 27 months in the glofitamab compared to 21 months in the epcoritamab. And as you can see, CRs and ICANS were pretty low in both studies. Here's a study, a prospective study, looking at giving glofitamab in first relapse progression after failing CAR T-cell therapy. I mean, the message here is that you have a pretty good response even in these patients. Overall response rate 66%, complete metabolic response 36%, and the median overall survival in these patients was 18 months. What about patients who have late failure of CAR T-cell therapy? This is a registry study from the French group, and it compared the outcome of patients who had received after failure of CAR T-cell therapy, chemo-based, targeted therapy, bispecific or radiotherapy. And as you can see here, the 6-month progression-free survival and overall survival looked better in those who had received bispecific. So going back to our case, as I said, he had received radiotherapy. We were planning on giving him polatuzumab in combination with bendamustine, but we found out that there was the registry study of glofitamab, and Roche kindly provided the opportunity for this patient to receive it. And he had actually progressed until we got the drug in our hands. He had progressed with the cervical, the stomach, T7 and muscle involvement. So he received his first 3 doses of glofitamab, and he achieved metabolic CR DeVille 1, and he's just completed 8 cycles of glofitamab and is due to have a PET scan. What about bispecifics before CAR T-cell therapy? Again, there's been a significant number of patients. There is some experience now using it. And as you can see, the overall response rate is 83% and CRs 43%. And there was a propensity scoring matching analysis comparing CAR T-cell without prior bispecific versus bispecific. And as you can see, there was no difference in the progression-free survival since the infusion of the CAR T-cell therapy. So in other words, infusing CAR T-cell, so giving bispecifics before CAR T-cell therapy is safe, and there is no issues regarding this issue. So regarding dissecting choices between these dual immunotherapies in third-line therapy in large B-cell lymphoma, I think what's important to emphasize here,
2 minutes.
2 minutes, sure, is that we have solid evidence that CAR T-cell therapy is curative, although for the time being with bispecifics we don't have that, so we should take that into account when deciding. Also, off-the-shelf availability, not applicable with CAR T-cells, but with bispecifics, yes. And of course, CAR T-cell therapy is only available in specialized centers, and bispecifics can be given in the community setting. I couldn't finish without mentioning allogeneic stem cell transplantation, because it is a form of immunotherapy. And here I just want to send the message that even for patients who fail CAR T-cell therapy, there is the option. I'm sure these are highly selected patients, but making this the correct choice, you might be able to salvage these patients. As you can see, the 1-year overall survival in this number of patients, 88 patients, was 59%, progression-free survival 45%, and GVHD relapse-free survival 39% in these patients. Finally, this is the treatment algorithm we have currently for patients with diffuse large B-cell lymphoma. I think it's clear to separate those who relapse within a year with those who relapse after a year, and we have a variety of second-line options, as you can see here, from CAR T-cell therapy to auto stem cell transplantation, depending on when you've relapsed, and a number of combinations and agents. for the second line therapy. And for the third line therapy, as you can see, we have CAR T-cell therapy for those who are not exposed to it, and all these immunotherapies and agents I mentioned earlier. I think what's important to emphasize is that there are studies now being designed looking at drugs that were in the third line setting to be moved to the second line setting, combined with various agents. It'll be interesting to see how this affects the long-term strategies we use for patients we're treating. Thank you.